Okay, welcome to Iowa. My name is Rich Tyler, and this is the 25th annual conference on tinnitus and hyperacusis. And I'm always careful to point out that I started this when I was 12 years old. So I want to be clear about that. So we're glad that you're here, and we want to have interactions. There'll be some time downstairs to circulate with some of the vendors. The vendors will be presenting their products tomorrow morning. There'll be some breakout sessions later on, and we look forward to your interactions and appreciate your support. So, I'll be giving the first presentation on some background information about tinnitus and the causes and mechanisms. So I've always liked this definition provided by Dennis McFadden. You have to hear it, it has to be involuntary, and it has to come something from inside your head, inside your body. It's not something you have super hearing outside. It's also, I've heard people say, well, it's a symptom, but hearing loss is a symptom. That doesn't make it better or worse. And also, I don't like to use the word phantom perception because for the patient, it is indeed real. So I never use the word phantom. The way that I've categorized tinnitus over the years, it's either a middle ear tinnitus that originates in the middle ear, or it's a sensorineural tinnitus, that is, that arises in the sensorineural system. And that, I think, helps us the way that we think about it and the way that we treat it. Our otolaryngologist will be giving a talk tomorrow morning, and of course they're mostly interested in middle ear tinnitus in the sense that that may be something they'll be able to treat. But we're going to focus mostly for the conference on sensorineural tinnitus. It could, of course, have lots of different causes. It could originate in the cochlea, many different mechanisms involved, or it could originate retrocochlear as well. And at this point, it's not clear. There's lots of speculations, and I'm going to summarize things the way I did a few years ago about what the most probable way of thinking about the mechanisms are. So it has to start, it can start anywhere, but it has to be perceived in the auditory cortex in order for somebody to actually hear the sound. It's also interesting that sometimes patients will come in and they hear music or they hear words. And of course, the issue there is to try and sort out if they actually have a mental disorder, in which case they need to be referred to a psychiatrist. Or I've actually seen people who do not have a mental disorder and just perceive different sounds. And Penfield from Montreal in the 1940s and 50s stimulated parts of the temporal lobe electrically, and people heard melodies and words and things. So it's important to appreciate that that can be a symptom in a few people as well. About a third of the people hear tinnitus in one ear. About half people hear it in both ears. A few people hear it somewhere inside their head. They can't be very specific. And it's very, very seldom that I've seen somebody that say they hear it, it sounds like it's coming from out there. Well, very, very rarely. This is the epidemiology, and the increases go up as a function of age. Its common cause is noise exposure and the aging process in general. As I sometimes tell the patients that you probably know somebody, one of your friends probably has tinnitus as well, but because it's invisible, you might not know it. You might not have discussed it with them as well. So the incidence varies depending upon how you ask the question. About 3 to 5% of the population at large, as much as 20 to 30% of the population over the age of 60. So this is an interesting slide because it describes people that have tinnitus. And they were asked what their hearing was like, and almost half of them said they had normal hearing. So these people that had tinnitus and said they had normal hearing probably did not have normal hearing. It's just that tinnitus was the most important problem in their life, and that's what they were focused on. You can also see that most of them had not purchased hearing aids yet. And so this is important because these people with tinnitus, who are focused on their tinnitus, not on their hearing loss, will also benefit from getting hearing aids. And that's an important contribution we can make to these people that need to hear better as well with their tinnitus. So a very small percentage of these had already purchased hearing aids, but most of them either think they have normal hearing when they really don't, or they're focused more on their tinnitus and not on their hearing loss. We also asked them how it impacted their life, and a lot of them say it's interfere with their ability to hear. Sometimes it's difficult to sort out whether that's due to the hearing loss or due to the tinnitus. They often say they have difficulty concentrating, sleeping, and then there are secondary activities I refer to as leisure and social life and work and things like that. But if you look at the very top bar, these people said they had no impact. The tinnitus has had no impact on them. And this reminds me that many years ago I had a grant, and it was reported in our university alumni newsletter that went out around the country to several thousand people. And I had about 50 emails in the next month, and they all pretty much said the same thing. They said, I've had tinnitus for 20 years, and it doesn't bother me. But if you found a cure, I will fly to Iowa City next week. So it's not an easy thing to quantify and to measure and understand, so it's important to keep that in mind. So the mechanisms have to do with spontaneous activity. So there's, of course, spontaneous activity throughout our nervous system, and there's chemical transmitters at junctions between the hair cells and the cochlea and the nerve fibers, and between the series of nerve fibers that goes up to the temporal lobe and connects to the rest of the brain. So tinnitus likely has to do with this spontaneous activity, and it could be there are some chemicals that increase the transmission, and there are some chemicals that decrease the transmission from one nerve fiber to the other. So you can think of tinnitus as being an increase in excitatory chemicals or a decrease in inhibitory chemicals. This is an example of a nerve fiber junction. So here's the transmitters being released across from one nerve fiber to another, and the chemicals being released and picked up by these receptors. And again, this is all embedded in chemicals. There are different chemicals on both sides of these, to the transmitter and the receptors. And it's important to keep in mind that it could be related to the decrease or the increase of those chemicals. Okay. It was very interesting when I first got started in this, and there was a lot of talk about tinnitus in the periphery, and it was also known that back in the 1950s and 60s, a lot of people who had tinnitus in one ear and were overwhelmed by it would go to their otologist, and they would sometimes cut the nerve in order to try and get rid of the tinnitus, and that resulted in no hearing in that ear. But it was only successful in reducing the tinnitus in about 30% of the cases. So they stopped doing that. I also noticed in some of the first masking experiments I would do that people would hear tinnitus in their right ear, but you could put in a very low level noise in the left ear and reduce the tinnitus. So it wasn't a cross-masking effect. I also had patients come into the laboratory who had tinnitus in right ear, and I put noise in the right ear and their tinnitus would go away, but they say, well, that's fine, but now I've got tinnitus in the left ear. So it clearly involves a lot of central mechanisms here. It's not simply something that occurs in the periphery. So this was a major issue when I first got started because a lot of the emphasis was on the cochlea. So I argued that we ought to label this as central tinnitus in many different ways. So there's now probably hundreds of different theories on what causes tinnitus and what's involved in it. And so several years ago, I sort of broke this down into 3 different categories. And I think that's still true. So the 3 different ways that I think the person could hear sounds, though when they're not supposed to, is an increase in spontaneous activity in some auditory system, somewhere in the auditory system. And that could be caused, as we talked about these neurochemicals, as an increase or decrease in spontaneous activity somewhere, or an edge effect where normally between visual analogy is the lateral inhibition between a black area and an adjacent white area, and there's lateral inhibition going between those two. And if there's a dead space, then there's no inhibition coming from that dead space. And so at the edge of the white space, you get an extra activity. Nelson King had suggested that. The second strategy, and I'm going to show you some pictures to try and make sense of this, is that what I would call cross-fiber correlation. So normally, throughout the auditory system, there's no interaction between fibers that are spontaneously active. There's some interaction and some coordination in the brain, but not as much as there could be. And it may be that there's an overreaction to that. And again, I'll show you the slide this. And the third way is that there might be more fibers that are functioning at the same frequency following a hearing loss at 4,000 hertz. And the example that I give there is that if you have a hearing loss at 4,000 hertz, what happens is you're losing hair cells in that region, and then within several weeks and months you start losing nerve fibers in the 4,000 hertz region. And the part of the brain that used to respond to 4,000 hertz is still functioning, is still there, but it's not getting any input. So that part of the brain now starts to respond to 3,000 hertz, and now you have more of the brain responding to 3,000 hertz, and spontaneously, even without stimulation, you hear a 3,000 hertz tinnitus. So all three of these are speculations. And of course, then we have the reactions to tinnitus. We have the tinnitus itself. We have the reactions to the tinnitus. And when you have reactions to these sorts of things, then there has to be some kind of involvement in all parts of the brain. So we've known since the 1940s that when you get upset about something, then different parts of the brain are active, corresponding to the different thoughts you have, whether it's fear or joy or upset or all kinds of things. So this is the spontaneous activity model. So the hearing nerve is normally spontaneously active all the time. When we say the word table, some of the nerve fibers excite, and that's how when the brain looks at all 30 or 40,000 of these nerve fibers, it says, oh, somebody just said the word table. In tinnitus, when there's no external sound, one theory is that there's an extra activity, and the person hears that as a sound. There's a sound out there. That's what my brain is telling me. The second theory is this cross-fiber correlation. So normally, there's not very much correlation between adjacent fibers, but if for some reason all the fibers started firing at the same time, the brain would say, hey, there's something going on here. There must be a sound out there. And the analogy that comes through this is that these are nerve fibers, and there's actually a covering, a myelin sheath around the nerve fibers. But if the myelin sheath was damaged, as it is here, then an action potential, electrical activity traveling along this nerve fiber has the potential to excite or activate an adjacent nerve fiber, which would result in that coordinated across systems. The third category is this auditory brain reorganization after the hearing loss. Salvi and colleagues came up with this. And as I mentioned, the hair cells are destroyed, nerve fibers lost in the auditory nerve, and then that part of the brain starts to respond to other areas. And there are, interestingly, a lot of therapies now based on this model. So we'll hear more about this, I think, from some of the other theories and some of the manufacturers as well. Sometimes this is referred to as a phantom limb syndrome. So if you lose a finger, in some situations you can still feel like the finger is there. And that's been used as an analogy. So the conclusion for this then is for tinnitus, it's got to be some hyperactivity or some coordination of activity. The auditory cortex has to be involved in order for you to hear anything. And I'm going to say, although there are 300 different theories out there, in general, at least for me, I like to break it down into these three possible theories. An increase in spontaneous activity, some kind of synchrony across nerve fibers somewhere in the system, and perhaps an overrepresentation in some regions that corresponds to the tinnitus pitch. And I'll come back to that again later when I talk about measuring tinnitus. If somebody has an emotional reaction, whether somebody stepped on your toe and you're angry, or whether you have tinnitus and you're upset and distraught, there are parts of your brain that are going to be active, and that's clear. There are also some other theories now coming into play that where the origination of the tinnitus is in different parts of the brain without the hearing mechanism being directly involved. And again, for the most part, these are all speculations at this point. So why should we be interested in measuring tinnitus? Well, I'm going to say that there are several reasons. For the patient, it might help them, and we'll see why. For the clinician, how could it help you? For research, we have to have a measurement tools. And also for legal cases. We won't focus on legal cases here, but we could talk about that later. For the patients who come in are often concerned about their mental status. Is this real? Am I making this up? Do I have a mental illness coming on? What's going on here? And just by telling the patients we can measure your tinnitus, just by telling them that, a lot of them say, wow, you mean that you can actually measure this? And this is real? And it's also helpful often for the partners of the spouses to appreciate this as well. And because of that, it's often useful to be able to point to something, and sometimes just pointing to the audiogram and showing 15 dB hearing loss dip can be helpful to say, look, here's some other evidence that there's some disease process going on in your auditory system that's possibly linked in some way to your tinnitus. So this is my caveat here. Remember, is the average normal hearing is 0 dBHL. So that's important. So for the clinician, having measurements of hearing can actually help you with the counseling. You might be able to determine the severity, how desperate they are, whether treatment is needed. Also, being able to quantify tinnitus might help you direct you to what kinds of counseling is important. And you'll see in our tinnitus activities treatment that we focus on emotions, hearing, sleep, and concentration. But if somebody doesn't have any problems concentrating, we could eliminate that module. We also want to be able to monitor progress in the clinic. Is somebody getting better, or somebody getting worse in spite of this, or they come back a year later and their tinnitus is worse? We'd like to be able to quantify that. In some situations, people are using some of these measurements to actually fit the devices. You might want to know which kind of noise spectra are effective in masking or partially masking the tinnitus. You might want to know what level of masker is required to mask the tinnitus. And in some cases, you might not be able to mask the tinnitus at all. You might want to know if there's a contralateral effect. You put noise in this ear, does it suppress the tinnitus in both ears? You might also want to know if you put a masking noise on for a while and then turn the masking noise off, the tinnitus is gone, sometimes for several hours. You might want to know that and quantify that in the beginning before you start providing your treatment. So now we're going to talk about the main ways of measuring tinnitus. Clinically, you can measure pitch, loudness, and masking. And I'm also going to show some experimental things we've done over the years to try and quantify and distinguish and highlight what's involved in tinnitus. So we can measure the pitch, the loudness, and the masking. So we'll start off with the pitch before we go on to the secondary aspects. So it's important to keep in mind, and I say this to the patients, you have your tinnitus and you have your reactions to the tinnitus. And those are two separate things. So you have whatever the characteristics of the sound are, the quality and the pitch and the loudness, and then you have some overall annoyance. And the overall annoyance that the patient experiences is going to be impacted by that individual and what their psychological makeup is like. We all have stress in our lives. Some of us are used to dealing with complicated things on a regular basis, and some of those are carefree, and some of us are very upset when something goes wrong, and these are all normal reactions. I've heard people say that the loudness of tinnitus is not that important. and I think that's a mistake. Does anybody here in the audience have tinnitus? Raise your hand. Okay. If you'd prefer to have a louder tinnitus, raise your hand. Okay? So loudness is important. It's when you do correlations across many subjects that the correlations are often weak or not significant because people have different definitions of loudness. It's not an easy thing to quantify. But loudness makes a difference. So we're going to make a distinction between, if you're going to do something to treat the tinnitus, like if you're going to do a drug trial where you're expecting to reduce the magnitude of the tinnitus, you should actually measure the tinnitus. And for example, you measure the loudness, and we'll talk about that as well. If you're going to treat the reactions to the tinnitus, then you want to measure the annoyance, the way it's affecting their lives. You want to probably use some form of questionnaires. Keep in mind that there's always going to be variability associated with every measurement, even hearing thresholds, as we know. Tinnitus is a little more complicated because some people will say their tinnitus changes from day to day. In addition to that, there are some patients that say when you present the stimuli, that actually changes their tinnitus. So this makes it very, very complicated. So from a research perspective, the best approach here is to establish the variability for each individual patient. And I've argued over the years that we should be looking at individual data, not at group data. If you can figure out what the source of variability is, like the fluctuating tinnitus or the stimuli affecting the tinnitus, that's critical too. Okay, back to pitch. So some theories of tinnitus have it related to the audiogram. We've seen some preliminary work suggesting that maybe if you treat the person's tinnitus with a drug and their pitch reduces, does that mean the spontaneous activity reduces? Is that evidence for spontaneous activity? There are now some procedures out, which you'll see tomorrow and downstairs, where the devices that are coming out are actually based on the tinnitus pitch match. And that might be helpful. We had suggested that, tried that in some patients a long time ago. And in particular these days, there's potential for putting in a notch in the region of the tinnitus pitch, whether it's music or noise or whatever you have. So keep in mind that many patients don't say they have a pure tone tinnitus. They have trouble describing it. It can sound like a cricket or a noise. But that doesn't mean that you cannot ask the person to adjust the frequency of your tone so it equals to the most prominent pitch of their tinnitus. And I choose my words carefully here. There's lots of different ways to measure tinnitus. Keep it simple. There's a nice device downstairs you can see. I'm going to demonstrate an old-fashioned approach which I think is useful conceptually this afternoon. You could do the test in the ipsilateral ear or the contralateral ear. If it's in the contralateral ear, you have to be careful of diplacousis. And the experience over the years is pitch matching can be very difficult, even for normal hearing individuals trying to match a pure tone to the opposite ear. So again, if you're interested in this to be very precise, you have to do it a long time. We noticed early on that sometimes it was at the low frequency edge of a steep high frequency hearing loss, but not in everybody. And we replicated this later on in a large number of patients with a careful attention to their audiogram shapes. So this is the description of patients' tinnitus, a cricket, a noise, tonal, others. And these are all the audiograms of the patients that said their tinnitus was like a cricket. These are all the audiograms who said their patients was like a noise. So these are the average audiograms for these different groups. And you can see they're pretty similar. This is the pitch match frequency, and they're pretty much all over the place except people who heard a tonal tinnitus. And in that context, it's almost always a high frequency match. These are patients who matched less than 2,000, from 2,000 to 4,000 hertz, from 4,000 to 8,000 hertz, and above 8,000 hertz. These are the individual audiograms. These are the average audiograms, and again, you can see they're not very different, no matter where the pitch match was. This is the audiogram shape. We tried to pick out people who had a flat audiogram, who had a low frequency loss, a near normal hearing, a notch. And when we did that, we found that the high frequencies were present in the pitch match and those that had normal hearing audiogram or a inverted U shape. So again, nothing clear. No clear relationship between the pitch and the edge of the audiogram. So again, we talk about tinnitus as if it's one thing. There are likely many different kinds of tinnitus, and even if somebody has the same audiogram, it doesn't mean that their tinnitus originated from the same mechanism. These are just 3 examples that I chose from that study. Somebody with a high frequency loss, their pitch match was down here to a noise. Somebody who did have a high frequency loss, a cricket-like tinnitus, and their pitch match frequency was just at the edge of the notch. And then somebody who reported a tonal tinnitus, and their pitch match was at the high frequency edge of the notch. Okay, loudness. So for tinnitus loudness, I'm going to say I want you to adjust the loudness of my tone so it equals the same loudness as your tinnitus. And this is one way we call loudness matching. The other way to try and get a loudness estimate of an individual is through magnitude estimation. And I could say, I want you to rate the loudness of your tinnitus on a scale from 0 to 100, where 0 is the very faint and 100 is very loud. I hear people now, and I read a lot, people saying, using the terminology VAS or visual analog scale. That's an incorrect use of the word visual analog scale. You could use a visual analog scale to measure the tinnitus handicap inventory. It's a way of obtaining the information. What you're measuring is loudness. You're not measuring a visual analog scale. You're using the visual analog scale to make the measurement. Lots of different ways of loudness matching. The most common one is a method of adjustment, as I suggested. Adjust the loudness of my tone so it equals the same loudness of your tinnitus. And I would always use a pulse tone unless I was interested in measuring effects of adaptation, because if you leave a tone on continuously, it can adapt in hearing impaired people. So lots of different ways. I would usually do it in the ipsilateral ear because recruitment can have a factor involved in this. So Jack Vernon and Mary Meikle noted quite early on that most patients that had tinnitus did a loudness match less than 10 dB sensation level. Now keep in mind, sensation level is not a measurement of loudness, it's a measurement of the level of a tone above threshold. So sensation level is not loudness, and a sound only a few dB above threshold can be loud for some patients. So here's an example of some of the patients we published on. This is their audiogram, the pitch match frequency. The dB sensation level was only 2 or 3 dB with this open square at the high frequency hearing loss. But when we did the loudness match, down here at a very low frequency, was 30 or 40 dB above threshold. And that's okay, it's just due to loudness recruitment, as most of these people have. We also noticed in these early study, much to our surprise, and this is the loudness discomfort levels, that many of these patients with tinnitus had very low loudness discomfort levels. And as far as I'm aware, this was the first time that anybody had documented the relationship between tinnitus and hyperacusis. And we're fortunate today that lots of people are interested in hyperacusis, and that's going to be one of the foci of our presentations. So this is the relationship between stimulus level in an arbitrary scale and loudness from 0 to 100. This is normal hearing, A, 0, arbitrary scales up to 100. Somebody that has a hearing loss and has loudness recruitment is B, so this person has a 40 dB hearing loss, but their growth of loudness is rapid, loudness recruitment. Somebody with hyperacusis might have a hearing loss, But at a very lower level, 60 dB above threshold here, it's very loud. We're going to hear a lot more about that. We suggested that one way around this complication of people's loudness recruitment and quantifying tinnitus loudness was to adopt an international standard for measuring the loudness of a stimulus in sones. We suggested that people adapt that and use it for quantifying the loudness of tinnitus, not in sensation level, but instead in sones. And no one's done that, but at the time I thought it was a good idea. Okay, also keep in mind the distinction between loudness and annoyance. So generally speaking, a louder sound is more annoying, but across different individuals, different people have definitions of loudness and different tolerances of annoyance. And that's why I mentioned earlier that loudness is a factor, an important factor here, but what's loud for some people is going to be different for different definitions. So we would do the loudness matching, adjust the level. We would do loudness estimation on the scale from 0 to 100, and then either quantify that for an individual and see how that changed, or if we wanted to do something above groups, we could do a correlation and look at things across individuals by converting it to zones. We can also measure the minimum masking level of the tinnitus. So you're going to put in a noise, you increase the level of the noise until it just masks the tinnitus. And it turns out that this is a very well-documented procedure in normal hearing listeners, and my advisor Arnold Small in this department many years ago showed that the test-retest reliability in normal listeners to mask a pure tone is less than 1 or 2 dB. If you increase the tone by 20 dB, the amount of noise required to mask it goes up almost exactly by 20 dB. So this is a great tool for measuring the internal magnitude of the tinnitus, we argued. The amount of broadband noise required to completely mask the tinnitus. And you can do this with ipsilateral, binaural stimulus. The problem with this, I think it's a really accurate and repeatable within an individual. The problem with this in a study is that for some patients, you cannot mask their tinnitus. They're different. Lots of different methods you can use, a method of adjustment, an adaptive procedure. You can do it monaurally or binaurally, and the ipsilateral or the contralateral ear. We'll have a demonstration of that later, and you'll see some equipment downstairs. We talk about these references downstairs and later on. So I'm going to talk about just some experimental stuff we did. First of all, we did some work where we put in a noise to the right ear, we put in the exact same noise to the left ear. In this case, we put in 2 different noise. Here's the waveform of the noise, so this is a different noise waveform. When you do that, the person hears the noise throughout the head. If you put in the exact same waveform in both ears, particularly if it's a low frequency noise, you'll perceive the noise in the middle of your head. And then if you delay the waveform, so this is the same waveform here, but this one's delayed a little bit in one ear, you can actually move the perception around in your head of this noise. And so we suggested, gee, this might be possible to try and move the noise around to more closely focus on the person's perception of their tinnitus. And we found that at least in a couple of patients, the noise required to mask the tinnitus was much lower. We also looked at frequency-dependent masking. So I'll just show you the data here. So this is a summary of the data. A person's audiogram like this, they're pitch matched. For some people, you could mask the tinnitus at a very low level. For other people, at a very high level. Some people you could not mask. And for some people, you could use lower levels when it was close to the pitch match frequency. This is sometimes referred to as a tuning curve with tone-on-tone masking. And these people might actually have a peripheral tinnitus with the source on the basilar membrane. So those are the references for that. Finally, I'm going to talk about some post-masking effects. So several people had done this. We did it in a way that we were able to quantify the different effects. So for some people, you put in a masker, you turn the masker off, and the tinnitus hasn't changed. For other people, it goes away, and then comes back gradually or goes away completely. And for some people, this can be several hours. And this is also true for people wearing maskers or sometimes even hearing aids. For other people, the tinnitus gets worse. And in that case, I contacted the hospital attorney straight away. Fortunately, the tinnitus got better over time and returned to its other levels. So Vernon and Mikkel suggested these kinds of effects varied. Our experience is this actually depends on the level and the duration, however. Okay, there are many questionnaires available. One of the ones we used initially was an open-ended questionnaire, and I think this is very helpful clinically. So give it to patients online before they come in, give it to them in the waiting room. Make a list of the difficulties that you have as a result of your tinnitus. And we think when we have a formal questionnaire, we often think that that's clever and we're going to solve what we know all the answers. But the patient sometimes has their own perspective on things, and it's useful to have them tell us what's important in their life. And the open-ended questionnaire does this. There are many, many questionnaires, and one of the first ones we developed, the Tinnitus Handicap Questionnaire, was designed as a for some treatment studies we were doing, and it's been used worldwide in many different evaluations. A new one, the Tinnitus Functional Index, has 25 questions. One of the things I don't like about this questionnaire is there are several questions on the quality of life. So, for example, how much has your tinnitus interfered with your enjoyment of social activities? The further away you get from the tinnitus and the more you involve the person's life, your life is affected by how things are going at work, how things are going with your partner, what's going on in general, not necessarily related to your tinnitus. So I think this Tinnitus Functional Index made a mistake and is going to be less sensitive because of that. The recent one we've developed is the Tinnitus Primary Functions Questionnaire, and I'll talk about this in the measurement issues. Thoughts and emotions, hearing, sleep, and concentration. And there are no quality of life general questions on that. So I think these are the 4 primary functions involved. These functions, depending upon their activities, they can have an effect on work or socialization. And this is my interpretation of a World Health Organization strategy. Some examples are my emotional peace is one of the worst effects of my tinnitus. Some data I'm going to show you later on using the Tinnitus Primary Function Questionnaire and the different categories. So their open-ended questionnaires are very useful. We suggest for planning treatments and for clinical trials that you use the Tinnitus Primary Functions Questionnaire. Tinnitus can be measured. It can be very useful clinically, helpful to gain the confidence, and might direct your treatment plans. And so that's the end of that one.